Good.
So
Right.
yeah, just give it 2 seconds to go live on YouTube. And there we go. Go for it.
Yeah, so she was 44 years old in Asma Bay, and she's been unwell for the last 2 days with retrosternal kind of pleuritic chest pain on the right side. She woke up that morning with the right side pleuritic chest pain, and she was saying it was radiating to the right shoulder. She mentioned she was short of breath, so kind of pleuritic pain with shortness of breath, no other symptoms, nausea, vomiting, past history, depression, anxiety, and migraine. She is on oral contraceptive pills, which I didn't ask why she is 44 years on oral contraceptive pills and on medications for migraine, sumatriptan and Rizamelt, and some anxiety medications as well. So she was not a smoker. Family history on her mom, she died from heart attack in her 50s. So examination, she was afebrile. Her heart rate was 80, blood pressure was 118/74, breathing rate 14, saturation 98% on room air. So listen to the chest and the heart was all unremarkable. She denied any pain or swelling in her legs. So my impression was pleuritic right-sided chest pain, risk factor or contraceptive pills, PE needed to be ruled out, sent to emergency. I just checked her notes through the hospital. She had an CT for the pulmonary CT scan and angiogram as well. It showed multiple PE bilaterally, more on the right side lung, and she was admitted under respiratory. So it was quite scary.
Yeah, because it's a fairly low-key history, eh?
Yeah, and all stable.
Ob's pretty good.
Sorry, what was the nature of?
Sorry.
What did she come in complaining of?
Chest pain on the right side, which is a pleuritic, worse with the breathing. And I asked about shortness of breath. She said, yes, I can't take breathe. But because of the, depression, anxiety, and migraine, she's on as well with oral contraceptives. Sounds she's been on this for a long time. I don't know,
And she wasn't a smoker?
No, non-smoker. Is that like with the migraine? And she is on that one as well. I don't know what kind of migraine she's been experiencing, to be honest.
Unless migraines when she's on no pills and she just takes almost continuously to prevent the migraine.
But with stats of 98 and a respiratory rate of 14, you're thinking, well,
yeah,
pretty good odds for.
Yeah.
She didn't have a tachy. She didn't have a tachycardia.
No. Just her heart rate was 80 and everything was looking okay. She was looking good generally. And that was very unexpected, the whole findings for her.
Ben, can you go and get your please?
Sorry?
I think Jackie's trying to send us to bed.
I was on mute, sorry. No, toothbrushes for Ben, not for you guys. How to mute myself, hang on.
And talking of unexpected things, Sharuk, did you see the thing I left you in your pigeonhole of the guy with hematuria you had?
Yeah, which one? Oh, the one with he had renal cancer, isn't it? Yeah.
I keep getting updates when I did the inbox, and it was actually quite a nasty thing that's invading his IVC.
Yeah, so sad. Yeah, I remember him very well. It was telling like this is another thing he mentioned. He said he got a blood pressure and taking medication. He said once my blood pressure goes up, I start to pass blood. So I'm not concerned about this. I start to get quite concerned. There might be something there which is very vascular. Once the blood pressure goes up, you start to pass like that blood, in urine. Yeah. So that was sad.
He's going to go forward to a combined cardiothoracic vascular urology procedure because basically it's going to have to might be going into his chest for that one. Right. So that's kind of a big deal.
Yeah. It's a lot of things being like really unexpected when you're seeing patients sometimes. That one was bit concern to me, that patient with the hematuria really, but yeah, that one of the 2 days ago was a bit scary, shocking, the results of her scan.
Totally. Those ones. I almost did I thought a guy who basically had an influenza type thing. This was three years ago, and he'd been cast in bed, and it was just the right history for a post-influenza pneumonia, because he'd become like progressively more short of breath. He'd been sick for a week, cast up in bed, then was getting better, then was getting worse again, and quite like obs weren't too bad, and I was like, oh yeah, it's probably pneumonia. I'd literally written the script for some anti-inflammatories for his pleuritic pain and some antibiotics, because otherwise his obs were okay. And I was handing them to him, and then he mentioned that his sister had a DVT or something. Because I say, well, it could be, like a blood clot type thing, but it's unlikely given the fact you're young and no other history. And he goes, oh yeah, my sister had one of those. Wow. Yeah. I was like, oh yeah, really? As my ears pricked up. And he goes, yeah, they did some blood tests and she had this factor 5 Leiden thing. And I was like, and I just literally retracted the scripts. I was literally like thrusting towards him at the time. It's like, oh no. And yeah, and they basically, the whole family had factor 5 Leiden that he'd kept from me the whole time. And his mum had it, who was there, and they hadn't thought to mention that. And so I said, actually, you need to go to hospital. And he had a saddle embolus. And I was like, man, I so almost let that guy walk out the door with that was like, holy fuck. So yeah. Alrighty. Does Jackie have any cases to talk about?
No, not really.
Okay.
I know that's not very interesting.
Well, we spent the first half an hour looking at my pictures of birds and talking about POCUS. So that's how we spent the first half an hour, and then you joined just as Europe was actually doing something sensible. So yeah, I mean, this was a fairly last minute peer review, so it was kind of a limited interest. So we can look at some x-rays, I guess.
Yep.
I don't know, I can't. Oh man, I'll see if I can log into Anglesea and find something interesting. Just bear with me. If we all get disconnected, I'll restart the meeting, but just bear with me because I need to log into the VPN.
Do you want to look at my x-ray of the man that you saw, Tay saw, and I saw?
Oh, okay.
We talked about it, Paul, a little bit at the end of today, just because it is x-ray.
Given that to the end of today was more than 3 hours ago, you might have to give me a little bit more of a clue.
Okay. 60-year-old gentleman, works as a plumber, but was at home. He had his drink and lunch in one hand and one arm, and the pile of papers in the other arm. And as he walked through his door, he didn't know that the dog was going to be in front, and unfortunately tripped over his dog with all of these things in his hand and landed flat on the ground, and then had a right wrist pain, which he was seen in Anglesea on the 30th of September. And I was on the end of his reviews. But are you able to get into Anglesea?
Yeah.
Yep.
When did you see him?
So I saw him today, but his original journey sort of started on the 30th of September.
Was it Brigham or Nicholas?
Nicholas, Mr. Moth. Yep. and he's had 3 images of the same right wrist since then.
PWW 4155. PWW. Oh, 455.
An ice cream or I've got from the dairy garden.
There we go. Screen sharing up. Ding, 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 ding. There you go. Dunk. Alrighty.
You're the boss. I ran out. I need to make some tonight, actually.
So, anybody want to talk about these X-rays?
Oh yeah, that's the airlogs.
What is the?
Triquetral.
Yep.
That little
What else
fleck.
can you see?
Where else? I can't see. A bit of a rough looking scaphoid. I think.
So he's got. Can you see my cursor?
Yep.
Yeah.
If you look in here, you can see this is what's called the STTJ, or the scaphoid trapezoid trapezium joint, and you can see it's just ragged, and it's a common place of wear which produces a chronic radial-sided pain, usually activity related. And you can see even his CMCJ has just got a little bit of spurring there as well. So he's just got a little bit of radial-sided wear. That's a osteophyte there. Radial-sided wear of his carpus as well. So there's that. But he also had something else. Oh, he's got a risk factor for it as well, Dr. Hackey. He's got a risk factor.
Yeah.
He does.
Got the distal end of his
So there's a
radius.
if you draw a line across the lunate fossa, you can see he's got positive ulnar variance. Most people it should be flat or a couple of millimeters shorter. But he's got positive, and that means he's more likely to get TFCC problems. That's what he got. But you can't tell that on an X-ray. That's a clinical sign. But he's got this ulnar-sided foveal tenderness, but he's got positive. And if your ulnar is very strong, long, you can get something called ulnar abutment syndrome, which is basically this just keeps banging against the carpus and making you sad. So let's have a look at the.
That scaphoid thing is just where degenerative, is it?
Yeah, totally. And yes, mainly STTJ, but he's also got a little bit of CMCJ degen. Neutral to slightly positive ulnar variance, and he's got that. So what is the complication of triquetral avulsion?
Non-union pain. Non-union, maybe.
No, it's gross carpal instability, and it happens to 0.003% of injuries.
What? Triquetral? I thought it was the second commonest fracture.
Yeah, I know, but gross carpal instability happens to 0.003%, which is not that common.
Right.
And those are the ones we know about. It happens to that percent. There'll be a bunch out there that we don't know about. So I reckon the instance is probably less. And that's why I tend to be fairly aggressive with these. Short period of mobilization, give them a splint, get them moving. Whereas the traditional books always said 4 weeks in cast, which I think is overkill. So I tend to get these moving, and I haven't had a massive wave of gross carpal instability being fed back to me. So yeah, so that's cool. Let's I will see if I can go back to my medtech to see if we can find any more interesting stuff.
He's 9 weeks and 2 days in on his injury, and he's been having hand physio and has a wrist splint. But he came back at the request of the hand physio to have a re-x-ray and review. And in terms of his ability to wrist flex, wrist extend, sorry, that's still a bit restricted. His ulnar deviation was, he said, improved, but still a bit restricted. And there was some sort of foveal tenderness. So he's continuing that conservative treatment and is going to see the hand surgeon for a bit of advice around his case.
Alrighty. Let's have a look at this one. This is a good one. Alrighty. Cool. Little boy fell off trampoline, sore arm, like he's 4. Anybody want to raise their head above the parapet and tell me what the obvious abnormality is? I will let you look at the radiologist report as well if you want. Does anybody want to see the radiologist report?
Having a look, just
Okay.
Okay, so we've all read that. It's clear, plain as day. Now we'll go back to the radiology x-rays, and you tell me what the obvious injury is. Anybody?
I'm thinking, is that slightly, oh, is that dislocated, that radius head?
Yes. So when you draw the line, you see this little bump there, that's the radial tubercle. So from there on is the radial neck. So you pick the center about there, and you draw through the middle, and then you extend your line out. So we agree that this is probably halfway between there, and that's where your radial neck is. Some might even say it's there is the middle of your radial neck. That should always go through the capitellum. Okay? On every view. There's no one view that you can do it where it could be okay. On every view, it should go through. And on that view, on the AP, it does. Okay? So, he gets put into a cast above elbow, brought back to fracture clinic at 9 days. And like he's just a bit miserable when the cast comes off. I tried pro-supination, and he's really sore doing that. And I obviously have a clue at what's going on already because I saw the x-rays and I'm quite sad. So I repeat the x-rays just to make sure. It's still out. Still in line on the AP view. Report of the episode x-rays. Normal.
Right, there's no fracture, but
I even gave them a hint, sore proximal radius, query occult injuries. So, yeah.
What do you do for that?
He needed an open reduction.
Oh, an
And I
open.
think he-
Oh,
and I
shame.
think he needed an ulnar osteotomy as well. Let's just say he would have done a lot better if that had been identified on the day of injury or 2 days after injury.
Yeah.
By the radiology report, not 9 days down the line.
And what does radiology say when you approach them and say it's desiccated?
Well, the reason I don't bother is because a few years ago, Hein went round to talk to them about exactly this thing.
Yeah.
And they just gave him arseholes. They wrote the snidest comments on the revised report.
My children are still up.
Yes.
Yeah.
So that's why I just don't bother. And you talk to Hein about it, he goes, yeah, don't bother. Just because they don't care. They just give you grief.
Yeah, even when they missed my daughter's bone tumor and were told, well, yeah.
Yeah, they don't accept criticism that well.
Yeah. It's a bit worrying.
Yeah, so this you can see why I'm don't rely on radiology reports as the gold standard, eh?
Absolutely.
And like, I hope none of you would miss this.
It's made us remember that we must look for it. So we shall.
I can actually tell you who did. So I've got the notes in front of me. Ooh. Ooh, it was them.
No, don't do that, Paul.
It was them. They should know better. Anyway, right. Let's see if we can find something else fun. So yeah, radio capitellar lines. Always draw the line. It takes 2 seconds. Who listened to my talk at boot camp?
Yes, I did.
Cool.
Not what it was about, but I listened. What was it again?
About X-rays.
Oh yeah, yeah. ABCs of X-rays.
Indeed.
Maybe see if it hangs out in the morning. Oh.
Bear with me. I just can't remember. My digit span test is quite low at the moment. 6630.
What were you going to tell us about your talk?
Oh, I just covered this topic. It's basically I talked about common os and avulsions, and of all the avulsions, this one is one of the rarer ones, which is kind of exciting. Teenage boys typically can be girls on athletic activities, usually running, can have avulsions of their growth plates. And this young man has managed to do an ischial tuberosity avulsion, and these are super rare. You're more likely to do ASAS, which is up there, off there with sartorius, and rectus femoris on AIIS. Okay, so ischial tuberosities are super rare.
Is it just it looks fluffy?
Well, you can see that there's a bit there.
Oh yeah.
That is not there. Different. He's also torn his right butt cheek, so you know that.
Yeah. I had one of those.
I had one of those as well, but the radiologist missed it actually. That was years ago.
Oh, an ultrasound.
And the ischial tuberosities are the ones you always send. The other ones, physio, ischial ones are the ones you always send.
You send them to the hospital to ortho?
No, you can send them to private. Steve McChesney is your man.
What are they going to do?
They have a low threshold for sticking them back on.
How do they do that?
Staple gun.
Pretty much what they do is
Stop.
get, if I can get the nice pictures up, go round to the boom. So they get into the conjoint tendon and they put some sutures in there, and then they use a suture anchor to drill it into the bone. And so they basically tie it back on.
Okay. Yep.
It's all down here, this stuff. That's a collection of fluid where it's come off. Okay. And the main reason is because it's so close to the sciatic nerve.
Oh, yeah.
Like it's literally next door neighbour. That what happens if you don't fix them up, they scar onto the sciatic nerve, and then every time you tense your hamstring, your sciatic nerve goes twing.
Yeah.
Which is not that fun apparently. So yeah, the low percentage, and I can't remember exactly what the percentage is. I can look it up if people really want to know. So yeah, that was a cool one.
And they just do that with quite an innocuous injury.
So this guy did it water skiing, which is the classic hamstrings.
Oh, okay.
It's
a high impact injury.
And usually the IIS and the ASAS are done through sprinting. So things like soccer or literally just sprinting.
Okay.
Just like, at sports or 100 meters.
Yep.
And
they get a sore bottom.
They get what?
They got
sore bottom. Yes. Sore hamstrings.
Oh, and hamstrings. Okay.
Yeah. I don't have a percentage other than the fact that it's rare.
Their bone.
What's that?
When you can feel it, like it would be tender when you push on their bone there.
Yeah, they have a lot of swelling and bruising, and you tend to like lose a little bit of your butt cheek fold there because of the swelling.
Okay.
Because that's exactly where it is. It's where your butt cheek fold is. You can see where kind of cruciate comes over.
Yep.
So it's exactly there, and there's usually like swelling and bruising going down the leg, just like any kind of hamstring tear. But it's a bit more proximal. So you're basically just into where the crease of the butt cheek is. If you poke your finger up there, you will be off their Christmas card list.
Yeah.
So, oh, this is a good one. This is another member of things to check. If I can find the right x-rays, bear with me. Anglesea. So here we go. This is a 16-year-old boy who I saw in Fractioning, and he had been seen. The chest x-rays are relevant, it's from years ago, so don't be distracted by that. He had been seen on the floor having been playing soccer, planted his foot and kind of twisted it, and ankle immediately painful, unable to walk. X-rays reviewed as no bony injury. Came to see me how long later? 2 weeks later, 16 days later. Still couldn't walk on it. Literally was too sore to put to the ground. What are your thoughts?
Is the syndesmosis a bit wide in there between the tibia and the fibula?
It is on that view, isn't it? So that's an interesting conversation to start with. So if we look at the X-ray on the left, you can see Because normally if this was going to be wide, you'd have to have tailor shift, wouldn't you?
Yeah.
But you can see that, you know, it's kind of maintained-ish. You know, it's reasonable the same all the way around. You know, it's not markedly different. I mean, you could even make this one a bit more accurate there, you know. It's maybe if you stretch it to there, but if you're looking down below there, it's reasonably smooth all the way around. There's no obvious tailor shift. And it doesn't have to overlap. So there are a few signs that they look for, and it's not, you know, it's not a, if you have one, it's definite. They're all kind of a summation of things. So when you draw a line up the lateral wall of the talus, it should ideally be in line with the incisura there. And you can see there's a bit of a gap there, okay? This distance should be the same as that distance, and it's not much difference, you know, it's under a mil different. Okay, so those are the kind of things that you look for. Tailor, you know, lateral gutter, overlap, and the incisura lining up. And you say, well, there's definitely not an overlap there. There's definitely a bit of that, but the actual medial gutter looks okay. Now there is documentation that says he was fine. So what are your thoughts?
Then you better check the distal, I mean the proximal.
Proximal.
Yeah, I mean the person who saw the document to say that it was, but I fondled him up there and he didn't like it. So I thought we should get an X-ray. Where's the X-ray? Oh. And would you believe it?
Was this 2 weeks after the injury? Did you say?
Correct. 2 weeks. So standard, nothing on X-ray. Come and see me at 2 weeks. But a little bit more than 2 weeks because it was 16 days.
Was he not? Was he experiencing the pain in the ankle?
Yeah, totally.
More so than up there.
Very much so. He couldn't put his foot to the floor because his ankle was too sore and his ankle was swollen as. And even on this view, when you zoom it up down there, he still doesn't have much in the way of tailor shift, eh?
No.
Which is interesting.
Hmm.
So yeah, he went to hospital and got some internal jewelry.
Mm.
So if he doesn't have that tailor shift, do you think that his syndesmosis is intact?
I don't think his syndesmosis is intact
Hence why he had all the pain.
because he couldn't walk on it. I didn't stress him. I didn't see the need. I'd proven what I needed to, and that's he had a meson nerve.
Yeah.
And that was that. So, and so yeah, he needed orthopedics.
Excellent.
Actually, at the moment, I just this week had a young girl who's living in Falmouth, had been back to the States where she's from. And she had been skateboarding over there and wrecked her. Oh, she collided with a cyclist, I think, and hurt her ankle. Had it x-rayed there, which reported no bony injury. So I'm seeing her 3 weeks after the injury, how she's flown back and done her MIQ. And she still couldn't really probably put her weight on. But, you know, she's American, did it in America, although she's got residency here. You're not entitled to ACC, are you?
It depends on what your citizenship is here.
So I suspect she's only got residency. I'm not even sure whether it's a visa.
And whether you're working here or not, because you can get some coverage for overseas injuries. Because if I went overseas and got hurt, I would expect ACC would pick it up when I got back. But then I've been working here for years, just like the citizens, you know.
I might have to look into that more, because one of the things was I thought I should x-ray again, but I thought, well, if it's not covered by ACC, that's going to cost her over $150, and she's just a poor wee girl, you know.
Yeah.
So it made it a dilemma. So then I thought, well, go and see the physio and see what they think. I said the alternative was getting a bit of an ultrasound done by Michael Miller because he only charges a consult fee. So, I mean, really, there's still quite a bit of swelling. It's very hard to really totally localize where her pain was, but she just couldn't put her weight on her. She had a limp still, and this is 3 weeks down the track.
Yeah, so I've had guys who've been working in the mines in Australia do their injury there and come back. But because they're earning over there, they're not paying ACC levies here, then they're not covered.
So she's currently unemployed because I had to fill out a WIN certificate for her. So that she could be on, I don't know,
On a
excused
residency, that's a bit interesting, isn't it? She must have a really good residency.
Yeah. So I should actually fill out ACC for her then. Right.
Worth a go, isn't it?
Yeah.
Just make sure she doesn't rack up a huge bill in places, expecting
Yeah.
to cover it and then not.
Mm.
So yeah, it's worth a conversation with them to say, is this you or not?
Yeah.
Righty ho, shall we look at some big pathology? Let's see what we can make out of this young lady.
Ooh, doesn't look good.
I will read you the history.
Please do.
On monkey bars, fell on left elbow. Sore and swollen since, too sore to move.
Yikes. Well, she's dislocated the epiphyses of her radial head.
Anybody want to guess a Salter Harris on that?
No good at those.
It's 2.
Mm.
You can see that bit there.
So,
So it's a fracture dislocation.
Yeah.
It's clearly dislocated.
Yeah.
It's pointing in the wrong direction. It's not too far off. You could probably thumb that back in. Okay, so that's that. What else?
The electronon's not looking too good.
No, the electronon is not looking too good. So treatment for this is pretty obvious. A cast and an ambulance. So that one. Okay, this one's good. NDF 19 and 19. Righty ho, I will show you the x-ray and then I will read you the history. So, playing rugby, tackled, actually loaded his thumb.
Oh,
How? Hit the ground. Past medical history of tetralogy and fallow. And had a recent balloon dilatation. And I believe he works as an arborist, I believe. So, what do we think?
There's something funny at the base of his thumb.
Yes. What?
No, bone in the wrong place.
That is a highly technical term, Dr. Hamilton.
I'm not very good about those.
There's an orthopedic surgeon in the making there.
Don't give up my day job.
Acute bony unhappiness.
Yeah.
Shall we give it a stab at naming what bone it is?
Or try creature. No, trapezium.
trapezium?
Yes,
well, let's
Dr.
begin with
Green.
T.
Trapezium is actually the bone that's there. Dr. Haggie and Dr. Hamilton named bones on the other side of the carpus.
Oh,
I knew we had with a
oh,
T.
this one's there.
It
I
doesn't
thought it was-
begin with a P.
T, yeah, T, yes.
Right.
Bring up one of those words.
Cool. So you picked starting with the one letter that 3 out of the 8 bones start with. Nice.
Right.
So what he's done is he's got a sagittal split in his trapezium, which he's broken as he's dislocated his thumb. So it's a fracture dislocation of the CMC with a chunk of his trapezium.
Mhm.
So he was sent to hospital with that.
Oh,
And they'd wire that back.
You would think so, wouldn't you? But
But-
what they did is they pulled it straight and said, we'll give you a call.
All right.
And guess what?
It didn't work.
They didn't give him a call.
oh, crumbs.
And so 3 weeks later,
Oh my God.
he fronts up at Anglesea. Now, do you remember Kaya, who used to be on reception?
Yep.
This is his man, her man.
Oh,
And she's like, sort him out. I'm like, I don't really want to. And she's like, sort him out or I'll beat you up. She didn't say that. I'm just making it up. And so I was like, oh, let's do an x-ray and see how it's looking. And then I said, and I thought, well, crikey, as Mr. Owen would say, it's looking great. And I talked to plastics and they hummed and hawed about doing a CT scan and this and that. Or ortho, I don't remember who I talked to. And they again did nothing. And so I just followed it in cast. And serendipitously, he went on to heal.
phew. How young, sorry, was he?
He's 24 years old,
Yeah, yeah.
right-handed.
Yeah.
So there you go.
The body is amazing how it can heal itself.
Thank goodness.
Did you give it a pull before you put it in the cast to get it into a better
I
position?
did not see it. It was Dr. Glue, and I don't think she did. I think she declined to put it and said that the hand surgeons could do that, have that honour. So I believe he was reduced to the hospital,
Mm.
but he seems to be doing okay, which is pretty cool. Pretty lucky, considering he had an absolute failure to follow up. Other than me, obviously, I gave more than love.
Right.
Right. Let's look at another one, different part of the body. If anybody has got anything more interesting than me going on about x-rays, then you feel free to pipe up, or
No, I'm enjoying your x-rays.
if you want to change the topic, then again. Right. So, once again, I will show you some pictures and then I will read you a history. So, this young man,
Ooh.
he is 62 years of age.
Mhm.
He has a complete heart block with AF. He's got some mild right-sided plantar fasciitis. He does take some pills, but he can't remember. He normally walks with a frame due to his cardiac, I think, limitations. And he fell over, basically just twisted his ankle. Normally lives with a wife who works as a nurse at Waikato Hospital.
Well, he looks like he's a avulsed, calcified, where the Achilles inserts on the calcaneum.
Okay. Yep. Do you want to kind of take that idea and extend it, and you're pretty much on the money.
And well, that the Volspit's retracted quite a bit up.
So
Did
it's
he have like a large? Is it a Haglund's deformity or something that came off when he twisted
okay.
his
So
arm?
what's attached to what? Think about it like that.
I'm just wondering if
What's attached to here?
the Achilles would be on there.
Indeed,
Hercules.
because the Haglunds, this type of beaky bit there, is not where your Achilles attaches. Your Achilles attaches down here,
Oh, okay.
and so he's basically avulsed his Achilles.
Yep.
These are bad injuries, particularly if you're 62 and with a crap heart, because the only way you're going to fix that is by pulling it down and putting it through drill holes. But it also is really bad for the skin there because it's sort of like subcutaneous. And the worst case scenario is you actually rip the skin apart when you do it. Your second case bad scenario is that you basically have pressure on the skin from the constant pull of the Achilles and it becomes necrotic. And again, big hole, big problem, particularly with cardiogenic disease that needs a frame. So he's obviously not in the best of health. Yeah. Not that I want to bag the hospital, but he got a bit of failed to follow up there as well. Anyway, moving on. We all have times in our life when we don't do so well. But he kept on popping up and trying to get into my clinic, and I'm like, I have nothing for you, sir. Nothing for you.
So he did have nothing done. Is that what you say?
I don't think so. That's it. I'm just reading the rest of his notes, and 2 months later, we got a call regarding his death. There you go. So his Achilles is not a problem for him now.
It's only what 62? Did you say he was?
He would be 60 years. So 62.
Yeah.
His didn't even have his birthday this year. It's Christmas Eve, same day
Yeah.
as my son.
Ah.
But yeah, he's died. Probably his heart was crap or something. I don't know.
Bloody-
So, Paul, if he didn't die, like along Jackie's questioning, with his comorbidities and things, would they have touched him, or no, they wouldn't touch him?
It's such a hard decision.
Yeah.
It's such a hard decision, and
So
that's why I just wasn't going to willing to kind of get into it. I just like, I had the chat with him on the phone. I said, look, because this was all in kind of, it was August. It was lockdown time again.
Yeah.
And I'm just like, you're in a pickle. You really are. You are literally in a rock and a hard place. You've got no good answer. An operation is going to be a big risk to you. No operations is a risk to, the whole thing falling apart with a big hole in the back of your leg and then your leg getting cut off, which, at least would fix his plantar fasciitis.
So was he in a cast or a moon boot or something?
I think we put him into a moon boot with wedges or something. I can read the notes. Moon boot, 6 wedges. Just because of that, he was very frail looking, and if we try to put a cast in him and anything, he would just be completely cast. So. Achilles avulsions is a immediate referral. They can be bad, mainly due to the proximity to the skin.
How would we tell that clinically? Because
because he had a big divot just above his heel.
Right. Okay. Because normally we're just feeling for that dip in the tendon, and
He had
was low. His hole was low.
right.
Paul, what did you say? He had a big what?
Divot just above his heel. Whereas normally with Achilles, it's a few centimeters up.
Yeah.
Right.
And is it always quite a good chunk of bone, or can you just pull off a tiny bit?
Yeah, no, you can pull off a sliver, just like electrons. You can pull off a sliver.
Mhm.
Let's see. I think I've shown this one before, but you know, it's a goodie. So this gentleman didn't really want to divulge much history about what happened, other than he was the victim of an assault.
So there's a pneumothorax and a big burp in his stomach.
Pneumothorax, eh? Maybe. Anything else that's a bit more obvious? Yeah, maybe pneumo.
Where is he complaining of pain anywhere, or shortness of breath, or?
Left side of the chest.
Well, I just thought I can see those black lines. Which side of him am I looking at?
You
You see
can
these
see
black,
black lines.
yeah, and I kind of think, oh, is that a pneumomediastinum? Then
No, you're getting somewhere with the whole air is not in the right place.
yeah, you can see it on the right side of the lung and a bit round the aortic knuckle there.
Yeah. What structure would you see here that is kind of outlining? Pec, yeah. So if you can see pec like that, what's going on?
It's ripped open.
It's got surgical emphysema.
He has got surgical emphysema. You can see it all the way up down here. All up here, this is all surgical emphysema. And the fact you can see this outline, that's all air in there.
Yeah.
Okay.
Right.
Yep.
And what X-ray do I hate people requesting? Ribs. But can we see some rib fractures?
Yep, we can.
Oh yeah.
And
I know
remember,
that
for everyone
maybe.
you can see, there's 4 you can't. And I can see at least 1, 2, 3.
Hmm.
Is there one right at the top?
A rib. There is a rib right at the top. It's called the first one.
Yeah, is it? No, the fracture.
Oh, I think I'm so funny sometimes, Jackie. I do. Up here, you're thinking? I can't really appreciate it, whether it's kind of surgical emphysema. I seem to remember that first rib fractures are super bad.
Yep.
So anyway, so yeah, surgical emphysema, multiple rib fractures. I can't really appreciate pneumothorax that well. What's that?
So, can you point to the rib fractures for me?
There.
Hang on. Oh yeah.
See this line and that line doesn't kind of match up there. And here, there's a line coming down through there and another one there. If you kind of come there, there's a step there.
So I'm just trying to imagine if you saw him and not an X-ray, what is that? What would that wound look like with his pec all ripped? What
It
would we
wasn't
look
a wound. It's all inside. The skin's intact, is just swollen and bruised, and you have that crepitus.
Yeah.
Right. But like on the right lung there, you see how you got that black line across there. That's why I was thinking he had a pneumothorax because of the black line. Yeah, that's right. You're pointing now there.
Yeah, not sure what that is.
And there's a bit of gap at the top, isn't there? Oh, there's a fractured rib. Look up there, isn't it?
Well, someone thinking that, but like, no, I don't think it is. I think that's
No,
artifact.
no, there on the other
It
side.
carries
The
on.
other side. Other
This
side.
one?
On the right side. You come across to the right side. Yeah. No, right there. Up, right to your left or whichever. Yeah, there.
No, not sore there. That's way in his back as well.
Mm.
That's right in his back. He was sore on his left front.
Okay.
Yeah.
But it looks like a fracture.
Cool.
So Paul, because you always say don't do a chest X-ray for rib fractures,
Correct.
what made you decide that you should?
Probably the palpable surgical.
Firstly, not my patient.
What?
Okay. Firstly, this isn't my patient. But what would make me decide to do this is I'd want to know whether he had a pneumothorax.
Mm.
So he was symptomatic of that.
Yeah, he was really sore. By according to the notes and the doctor who saw him, he was and couldn't take a breath in.
Right.
Feels as though he cannot breathe. Had ibuprofen at home.
But I mean, you can have that with just a rib fracture, but no pneumothorax. He wasn't short of breath. Or
they decided they didn't want to have the police involved. Might indicate something. Got assaulted a few hours ago, punched by someone, declined to comment if it was a stranger or someone they knew. Family, patient didn't want police involved, wanted things to be confidential. Stats of 95, in severe pain, unable to move or sit upright, bending forward and in guarding chest swelling anterior left tender plus, reduced air entry left side.
Sounds very underworld. Underworld circumstances.
Really does it, Dr. Hackett? Well, yes. It does have that kind of...
What did the report say?
The X-ray report,
Yeah, did they get everything?
they said... Oh, I can let you read it through the power of magic. Fractures through the lateral aspects of the 5th to 7th rib extension associated with extensive surgical emphysema in the chest wall as well as mediastinal air. So there you go, in descending up from the root of the neck.
What's root overlying emphysema?
I have no idea. Could be due to overlying surgical emphysema, the left difficult.
Pneumothorax is suspected, yeah.
Small pneumothorax. No mediastinal shift. So there you go. So he went off to hospital. And I'm sure whoever dealt it had some recompense.
Mm-hmm.
And not through the courts. So that's been an hour and a half. Does anybody have any particular topics that they want to talk about, or do people want to go and put their children to bed, or
My Christmas tree before.
or should I try and find more X-rays?
Children to bed for me, sorry.
Yeah, I'm going to get to like that's great. You can save them for next time. We'll be looking to it eagerly. There's no Christmas get together, is there, for you guys?
No,
Not that we've been
next year.
informed.
Well, next time you have a party, don't forget to invite me.
I think there was a decision due to COVID or not to have it. I don't know, to be honest. I haven't.
I think
I have-
Julie sent something out about it being next year when we're a bit clearer about COVID, but we won't forget you, Ellie.
Alrighty.
Something about doing a Great Escape or something.
Yeah, that's it. Great race, amazing race.
Amazing.
And next year sometime. Amazing race.
Kind of
Please
team
don't tell me that we
building.
have to run somewhere, because that doesn't sound fun to me.
Yeah, that doesn't sound like your sort of thing, eh, Jackie?
When she said amazing race, I was like, great.
That sounds great for someone who's crippled with hip pain.
Yes. But what is the amazing race?
To be honest, I'm not 100% sure.
I think there'd be activities and challenges. It
Ah,
might be a pub crawl. Maybe it's a pub crawl.
I'm not too
Going
good
back
at
to mid school days.
That would be probably the amazing race most people would want to be a part of.
Yeah. Cool.
Just
A beautiful photo. You should get that one framed. Anyway, I'm going to sign off and go to the shop. They're shut. And lovely speaking with you all.
They're probably already shut in Whangamata.
I do half a week there, and so I'm back in Hamilton. And yeah, so they just do half my week over there. Back on Thursdays. I could have done it in person if you'd said so.
And that's all going okay. You've got a nice place to stay over there.
Yeah,
and-
very nice place to stay. And this weekend, for the first time, my husband will come over. I mean, I don't really go there on the weekend. I only go there Monday morning when I have to start work. But so we're going to make use of it this weekend. It's very close to the beach. It's nice, and yeah, we've got our
I
the
quite like Whangamata as a place,
is-
eh?
so that's what we're going to. Except I hope I'm going to be feeling fine because I've just had my booster today. Have you guys had your booster?
I haven't
Yeah.
had one yet, to be honest.
Yeah,
No, I haven't had mine yet.
I
Don't
keep,
worry.
it'd be so easy to keep putting it off because I was thinking, oh my god, I don't want to be, going home early from the party, because I feel tired or something. Anyway,
Yes, few of our nurses have gone down with their booster.
yeah. No, and
Yeah,
so far,
because I was going away to Dunedin, I didn't want to get mine done last week. Just because I didn't want to feel crap, so I could make the most of it and take nice pictures.
right. Well, I am off. Love you all, and see you next time.
See you next time.
Bye.
Bye bye.
What do you think of this one, Helena?
Gosh, that one's nice, yeah. So is that Dunedin?
That's Dunedin, that's sunset.
Oh, very nice. Were you doing a course down there or a holiday?
Yeah, I did a poker's course, and then I took a few days. 2 days, to be honest.
You were going to do it at Queenstown?
Yeah, and then I got locked down, so I couldn't go.
Oh, yeah.
I had to go to Dunedin.
Oh, that's a bit of a shame. Not that Dunedin's not nice, but...
Well, I don't like Dunedin as a place. I fundamentally dislike it.
Oh, do
you? Yeah, I just never liked the vibe of the place. Just doesn't do it for me.
Oh.
So yeah, I just generally don't like it. So, but always make the most of where you're at. So I took down all my camera gear and like hiking gear and basically went and did.
Oh, well, that's good.
So
How long were you down there?
I left on Thursday morning and I was back Tuesday evening.
Oh, yeah. Cool. Oh, that sounds good. Right. Well, I expect to better go and put these children to bed because they're supposed to have gone to bed on their own, but they haven't. So,
Really? You surprised me.
yes. Right. See you at work sometime.
See ya.
Bye.